I think we're on. So I'm in the north of England, and I'm talking to Dr. Lisa Fitzpatrick, who is in. Where are you, Lisa, at the moment?
I'm in Washington, D.C. in the United States.
Okay.
And it's raining outside.
Sorry?
And it's raining outside.
You know, it is here as well. You know, we have more in common than we think, I'm sure. So, what's your kind of background, Lisa? Why are we talking?
I'm an infectious disease doc who trained in public health at the Centers for Disease Control, which is the nation's public health agency here in the U.S. And I have a long career across the health sector. I graduated from medical school in 1992, and it's been an adventure since then. So after doing my infectious disease training and then going to work in the Epidemic Intelligence Service, which we playfully call the medical CIA, I worked at CDC for about 10 years and then decided to leave government so I could be closer to community. So I started working pretty close to the ground in 2007 and had an academic position. I've started a nonprofit. I've run an outpatient clinical center. I've served as the medical director for one of our healthcare financing agencies. And so I've had all sorts of jobs across the health sector, but what I'm most passionate about is helping people understand health information. So health literacy is my focus now.
Yeah, that's good. So just before we go on to the pandemic and talk about the health literacy thing particularly, is infectious disease a big problem globally and indeed in the United States?
Oh my goodness, yes. So when people think about infectious diseases, I think it depends on what's top of mind for you. Like in some parts of the world, people might think about tuberculosis. In some parts of the world, like people might think HIV. But the truth is, infectious diseases touches every body part, every organ system. It's relevant for all aspects of health and wellness in medicine. So you can get brain infections or meningitis, lung infections, pneumonia, kidney infections, bladder, we might call them bladder infections. And so diarrhea is a form of an infectious disease. So we see all sorts of things in infectious diseases.
And presumably infectious diseases are killing people all around the world then, if it can cause this wide variety of infections.
Oh, absolutely. I would say probably the top infectious diseases that harm people around the world, I would say malaria, tuberculosis, HIV, diarrhea. And diarrhea is an interesting one because largely it's from not having access to clean water. So it sounds like it's something that could be prevented quite easily, but we still have a long way to go. And even malaria, I know there are lots of efforts to try and eradicate malaria. And hopefully that's a goal we can achieve one day because, those pesky mosquitoes, I don't know that we'll ever get rid of them, but if we could figure out a way to eliminate this awful disease, then we'd save a lot of lives.
And of course, I assume infectious diseases can kill people at any stage in life, Lisa. We're not just talking about a few old people dying here. We're talking about children dying, babies dying, young adults dying. Is that the case?
Well, when you're thinking about people around the world dying from infectious diseases, that's absolutely true. And so, as I mentioned, not having access to clean water, a lot of us, so maybe you there in the UK and here in the United States, we don't really think about the impact of not having clean water because we take it for granted. But there are so many places around the world where people don't have access to clean water, and that ultimately kills millions of people. And from, young to old.
So, yeah, simple diarrhea caused by simple lack of clean water. I mean, it's just outrageous that this is still happening, isn't it? And yet this is a common global problem. And things like chest infections you see in many poorer areas around the world as well. So, I mean, presumably most of these chest infections are preventable and treatable. Do you think, Lisa?
Yeah, sure. And I think so. The one that comes to mind we're still struggling with is tuberculosis. Still very common, even though we don't talk about it that much, probably in your country or my country. but it's transmissible by it's spread, by air or having people around you who are in close proximity, people in your household. So when we do what we call contact investigations for people who have tuberculosis, we first look at their family members. So we try to figure out who they've been around. It sounds probably pretty familiar compared to what we're doing right now, right, for the pandemic. And I think it's interesting that people are now waking up to contact investigations, but it's an age-old practice that's been around forever. So for people with tuberculosis, this airborne infection, looking at who they've been around and then testing those people and protecting them from getting active tuberculosis. So there's a difference between being exposed to tuberculosis and actually having the chest infection from TB. And so the public health departments or people in ministries of health around the world, they're very accustomed to doing these investigations. But TB is still a very serious and significant condition, as is HIV, and I also mentioned malaria. I mean, these are infections that keep people busy, but also kill people, unfortunately.
Yeah, and as well as the deaths, of course, there's the whole burden of the morbidity, isn't there? People can be sick for such long periods of time, unable to look after their families, unable to attract a wife, unable to look after children, unable to attract a husband, and just be a non-economically productive for such long periods of time.
Yeah, my big concern there, though, when you put it in that, when you frame it that way, my big concern there is the mental health toll sickness can take on people. We don't talk about depression and anxiety and mental health disorders very much. It's very much stigmatized, but it's important for us to recognize that people who are ill or affected by these different conditions need support. And I don't care where you are, whether you're in Africa or the United States or the UK, South America, wherever you are, if you are afflicted by a chronic illness, you need support, not judgment and shame, which is a lot of, my work is also around trying to eliminate some of the stigma associated with being sick, because nobody wants to be sick. So we need to really learn to support each other.
Yeah, I think a lot of people don't realize this. Any significant physical illness, I would say, is likely to cause a degree of depression, certainly anxiety. And then, of course, the depression becomes a bit of a vicious circle, doesn't it? And, depression can be a debilitating illness in its own right, as well as the initial illness.
Yeah, absolutely. And because we don't talk about it, it creates an even bigger problem. It exacerbates the problem, as we say. So this is why we have to talk about these things and show people they're not alone. Like, there are millions of people who are struggling just like you are, and we all need to be talking about these things. It's a very human condition.
So just before we come on to the pandemic, Lisa, you're working in Washington, D.C. now. This is the heart of one of the richest, most civilized nations we would imagine on Earth. I mean, you're not telling me you see infectious diseases there as well?
Oh, come on, John. Yes, we are. Absolutely. We may not see them to the degree we see in other parts of the world. So we were just talking about malaria and tuberculosis, for example. We see an occasional case of malaria compared to what they see in Africa, but it's usually someone who's traveled or someone who's come from Africa to live here. And luckily our tuberculosis control efforts have been great. So we are seeing a lot less TB than we used to decades ago. But we still see too much HIV infection, for instance. Certainly pales in comparison to what you see on other continents like Africa. But yes, we still struggle. That's why there are so many infectious disease docs in the United States, because there's a need for us to be here.
Absolutely,
We haven't talked about hepatitis. We see a fair amount of hepatitis these days as well.
So we're talking HIV, tuberculosis, and hepatitis. Presumably all the types of hepatitis, A, B, C.
Yeah, so hepatitis A is, worldwide. So when I've traveled, I've had to have vaccinations.
Yeah.
So if I'm going, let's say I'm going to Africa, I might have to get quite a few vaccinations, or if I'm going to India. And one of those is hepatitis A, because hepatitis A is just spread by, it's what we call fecal oral. So it goes in one end and comes out the other. And so usually it has to do with poor hand hygiene. Maybe someone's cooking food for someone, and somehow the hepatitis A gets into the food. Hepatitis B is usually through bodily fluids. Hepatitis C, for a long time, we thought was associated with injection drug use, but now we're seeing increased rates of sexually transmitted hepatitis C as well. And so it's still, it's still something we see, but I would say, if you're ranking globally the infectious diseases that we need to be on top of, it's those few I mentioned in the beginning: malaria, TB, HIV, diarrheal illnesses.
Yeah. So HIV, tuberculosis, hepatitis, is there any other particular infectious diseases you see on a common basis, Lisa, in your regular practice in Washington?
No, I would say my primary practice, mostly HIV and hepatitis. Yeah,
right,
here in
okay.
Yeah. Occasionally, when I worked in the hospital, I might see what we call sequelae of HIV or infection. So people who have such weak immune systems, they're prone to other types of infections. But because of access to treatment for HIV, we stopped seeing we still see them, but not as much as we used to before the treatments were available. But I would say primarily HIV, hepatitis, occasional tuberculosis, but not so much.
Yeah. So if someone's taking regular antiretroviral medication, that's going to reduce their viral load, Lisa, isn't it? Is that going to make them less infectious?
Oh, absolutely. Yes. So there's so there, if people have been following HIV, they've probably heard this movement to help people understand. It's called U equals U, which means undetectable equals untransmittable. So essentially, it's telling people that if you are on treatment and your viral load is contained, and so the viral load is the number of copies of HIV that are in your body or in your bloodstream. If that's undetectable by the test, then we're not seeing transmission. So this is really great news. And I mentioned I started working in hospitals and in clinics in 1992. So back then, we couldn't say that. And we probably, if I were to transport myself back to 92 and tell myself that we would be talking about being undetectable because of medications, and even a single pill a day, I wouldn't have believed it. So it's quite a scientific and medical breakthrough that we can.
It really is. Yeah.
One pill a day. And now we're talking about long-acting injectables so that you can eventually just take an injection and not have to take pills for a while. So, but that's to become, that's on the horizon.
We're not actually talking about a cure here, though, are we? This is a lifelong management situation, isn't it?
So far. But I think the science is evolving, and you never know. We could one day have a cure for HIV. And I don't know if you know, but there has been evidence that bone marrow transplantation can cure HIV, but that is quite a drastic intervention. And this is actually something that was found by happenstance in a person who had HIV and a bone marrow transplant. And after his bone marrow transplant, they were unable to find his HIV. And so we know that there's information out there that could potentially lead to a cure, but bone marrow transplantation is risky and also carries its own morbidity or risk of death. So
sure. Yeah. That's really useful background, Lisa. It's, very interesting. How's your pandemic been? Let's go back to when did you first hear about SARS coronavirus 2?
Oh, John, you're going to take me back there. I have to say, I have been so humbled by SARS-CoV-2. I remember in January 2020, and there are two instances I think back on, and I say, wow, if only I knew then what I know now. Yeah. The first one is a friend who called me and said, should I be worried? And I said, oh, no, absolutely. This will blow over, because I thought it would be like SARS and MERS and it wouldn't really come here. And if it did, it would be contained so quickly. Yeah. And the second one was a friend who called me and said, I'm so sick. I feel like, I have the flu. My doctor said I have the flu, but this just doesn't feel like the flu. Like, what do you think I should do? And I told her, well, just, ride it out, like stay home and, stay in bed. It never crossed my mind that she could have COVID-19. And I'm pretty sure looking back, that's exactly what she had. In fact, I think I had it back in December
19.
Yeah, but knowing that at the time, I mean, it'd be impossible to really know that. But the reason I think that I traveled a lot in 2019. I mean, I had gold on one airline and silver on another. So I was traveling a lot. And I remember being so sick with a respiratory infection. And when I get a cold, it usually blows over in a few days. But this one was just hanging around and I was in bed. And even as I got better, I was still coughing a lot. And I just thought, am I going to be stuck with this cough? Like, what is this? And in hindsight, I'm pretty sure that's what it was. But, we didn't really take this seriously until several weeks after the physician in Wuhan, Dr. Lee, right? Who said he raised the alarm, but I think we didn't really take it seriously. But by the time he recognized that, can you imagine how much coronavirus had been was being transmitted in the weeks even before that? And so that's why when people say, well, did this start in January? I actually think just based on, I'm an epidemiologist, so I start thinking about, epi curves and or when is transmission really starting and how many people, could have had this and not known. And so by the time it comes to someone's notice, it probably means that it's been going on quite a while before you can actually see the evidence of it. So, it's been a wild year, and coronavirus it's fooled us time and time again. I mean, who would have thought we'd still be dealing with this now, or that it would surge so many times? So
that's what you've seen over the last year, Lisa. You've seen cases go up, go down, go up.
Yeah, but I think that's kind of the story around the world. I think first of all, I think there's fatigue for sure. I think we're all fatigued. Yeah. Tired of the mitigation strategies, not seeing our loved ones, having to wear masks. Yeah, all that's a drag. But I think if we could all just do it for a time, even when we had the early lockdowns, I think part of the problem was everybody didn't do it. We also continued flight. I think that's also a big issue.
Yeah. Flying in and out. Yeah.
So flying around, and it's such an easily transmissible organism. Well, I think that's why we're still here with this, because we still don't have everyone following the public health guidance.
Yeah.
And it's just allowing coronavirus to run around doing whatever it pleases.
Sure. In your own particular area, Lisa, in your own particular communities, what sort of factors have been influencing the transmission of the virus and the way people are suffering from the virus?
Yeah, well, in the United States, and I have to say I haven't followed closely what's happening globally because so much of my work is intensely focused here. But
Sure.
here we're seeing disproportionate deaths and hospitalizations among people of color, particularly Black and Hispanic people, Native American people. And this is related to a bunch of factors. One is if you live in the United States, you're more likely to be poor, have high stress levels, live in crowded living conditions, work on the front line if you're a person of color. And so if you're someone who can't follow the public health guidance, like, someone who can afford to stay home or work from home or be isolated from other people, and who frankly just has a more peaceful life, then, those, if you don't have those luxuries, you're going to be at higher risk of getting COVID-19.
And do you think that's true for all of these communities, the Black African American community, the Hispanic community, the Native American community?
Absolutely. I think the crowded living conditions or, not having the luxury of having your own apartment and your own bathroom. So, early in the pandemic, I was asking some of these questions to some of our social service providers, like, what do people do if they live in a household and they have one bathroom? And people would even ask me, well, we only have one bathroom. What am I supposed to do? And I remember talking to a police officer who was concerned about being out in the community. And she lived with her mother who had, people who are at high risk for COVID-19 and poor health outcomes, usually people with diabetes or heart disease or other chronic health conditions. And she was concerned at being a police officer who's out in the community, she might take, coronavirus back to her mom. And so she had to scramble to find a place to go after work every day, to shower so that she wouldn't expose her mother. And I think these are considerations. A lot of people who don't live in underserved areas, who have a comfortable income, they don't have to think about these things. And so one thing I think is a positive from this pandemic is how much it's shining a light on disparities and helping people realize how lucky they are to have the financial means or to have the ability to keep them and their loved ones safe from coronavirus, because so many people don't have that luxury.
Yes. And we've both seen this domestically, probably more so for you than for me, but certainly internationally, where basically someone's social standing, their economic standing depends on whether they get a disease or not, and indeed sometimes whether they die or not.
Mm-hmm. That is very true. But even before the pandemic, I've been looking at these health disparities, whether it's HIV or hepatitis, chronic health conditions. Cancer is another big one. Diabetes, heart disease. It seems, and most of my work is with Black Americans, and it seems that we lead almost every morbidity statistic, meaning we get sicker at higher rates than everybody else. And I think some of that is related to poverty, some of it's related to not having access, but some of it's frankly just related to it's stressful when you live in a society that, treats you with disrespect or, when you're confronted with racism. And racism can be very subtle, but it's stressful. Have ways to offset that stress.
I mean, I don't pretend to understand the American culture, but I can completely relate to.
I don't either.
to what you're saying. So just before we look at that, I mean, I'm assuming that the comorbidities in these disadvantaged communities, are we talking about increased rates of smoking, diabetes, obesity, hypertension, those sort of things, the chronic conditions?
Yeah, absolutely. I haven't looked at the racial disparities in smoking. I mean, we still have more smoking than I wish we had in the United States, probably in all groups, including in young people. And I don't know that it is higher or lower in in one race versus another, just because I haven't really studied that. But I do know in the Black community, we do have disproportionate rates of those chronic health conditions you mentioned: cancer, disease, diabetes. Yeah.
So diabetes, obesity, high blood pressure, cancers, more prevalent. Now, there's been a lot of. What about alcohol? Is that a problem in your communities?
Oh, it sure is. But you know what's interesting about this is, we need to be talking broadly about behavioral health and the disorders under the umbrella of behavioral health. And so we tend to separate or silo mental health issues, so anxiety, depression, all those things, from addiction. And addiction doesn't get the attention it deserves. And so when people talk about alcohol, it's interesting to me that we don't include that when we talk about addiction and the need for treatment and to ensure people have access to the services. I mean, there's a lot of stigma around addiction, but we need to do a better job integrating mental health and addiction so that people recognize this is about behavioral health. And we all, at some point in our lives, will be struggling with some sort of mental health disorder, even if it's just situational depression. Like today, my brother died recently, and just the grief that comes from, having something like that happen, it can give you situational depression, and it's nothing to be ashamed of. And so we are very good at stigmatizing people and their health conditions. And so you kind of touched a nerve when you talked about alcoholism, because I think we don't think about people struggling with these conditions, and we need to be more compassionate and more open and be there to support people and help them get resources when they're ready.
No, I agree. I mean, I've for decades now, I've considered alcoholism to be a disease.
Yeah.
And the people are victims just the same as any other disease. And like you, I've come across very judgmental attitudes even amongst healthcare professionals.
Oh, absolutely. That's right. And we're talking a lot about opioids now. But the thing about opioids is, it's an addiction, but so it's alcoholism. I mean, there are people who are addicted to food, and we have the whole range of addictions. Nicotine, incredibly addictive. And so why are we singling out one or two things, to say, oh, well, this one is causing so much death and so much destruction? But we need to be more holistic about it. It's as if we're putting one addiction over the other rather than treating addiction holistically.
Yeah. I'm just going to just say something personally. You probably saw me slightly affected there when you said you'd lost a brother. I've lost a brother recently as well. And, as you say, the grief is it comes in waves, doesn't it? And it's yeah. So it's a terrible thing.
Something you don't expect it, right?
Well, my brother was quite a bit younger than me, so I certainly didn't expect it, and But yeah, family grief is perhaps one of the worst emotional pains that you can go through. Yeah. So anyway, listen, we've talked about the living conditions, the comorbidities, as increasing the spread in disadvantaged communities. The other thing is disadvantaged communities seem to have suffered more mortality, more severe disease and more mortality compared to other communities. What kind of factors are in play there, do you think?
So I think what's happening there is, so let me just tell you a story. So I live in one of the underserved communities I serve. And in this community, and one of the reasons I moved here was because I wanted to understand the culture deeply. I wanted to embed myself, kind of like anthropologists do, so that I could see what's really happening. And so when I moved here, I was alarmed by a lot of the things that I wasn't used to, like the sound of gun violence. I would hear gunshots and just be appalled. Or I might
terrifying,
Yeah, right. And it affected my interest in walking outside. I was a very active person before I lived here because I would just walk outside or ride my bike. And I do a lot less of that now. But the point I'm making about living here after a while is when the gunfire rings out, it doesn't faze me. I don't stop what I'm doing. I don't, try to figure out where did that come from or who might be affected. And imagine what it's like to endure traumatic things like that your entire life. And it becomes so normalized, but you have to be affected. You just don't notice it. Wow. And so what I think is happening is that this is an accumulation of toxic stress. And so people, let's say the baseline level of stress, let's say it's a 1 across the board. That's normal. But if you live in a community like mine, maybe it's 5, but then you become used to the 5 and it's just normal. But it's still doing damage, right? Stress, we know stress really affects your immune system, health and well-being. And so if you live in a toxically stressed environment, but you've accustomed to it, your body has become adaptive to that. But at the same time, your immune system may not be strong enough, as the person whose stress level is at a 1. So when you're confronted with something like coronavirus and you have diabetes or you're obese or you have heart disease, that's like a double, triple whammy. And that's what I think is happening. And we're not talking that much about it. And I think because we don't necessarily have the science to back it up, but I think that's, from my observations, that's what's happening. Like people are surrounded by toxic stress. They're at baseline. They're not as healthy as someone else. So when an insult comes, they're not in a position to fight it off as much, as strongly as someone else might.
I think everyone would agree about the relationship between stress and reduced immunity.
Yeah.
But I hadn't kind of realized until you said that is that the stress can be like diffused through an entire community. So you can have a whole cohort of people who are living under these stress levels, for example, from gun violence, which is.
And the fact that you don't notice it, that it just becomes normalized, but you're still stressed out by it. I get crime alerts on my phone. And a few weeks ago, I was thinking to myself, should I be getting these crime alerts? Like, what is it doing to me subconsciously? Even though I don't feel affected in that moment, but is it doing something to my hormone levels or, just to my general well-being to actually even look at these crime alerts and see where they are in proximity to where I live? But those are the things we don't think about, but I think it really is affecting people's health. And I often like to tell this story about a little boy I saw on the train when I first moved into my neighborhood. So I take public transportation, or at least used to, a lot. And, coming from a more affluent part of the city into this part of town, my tolerance was just not great at all. And I got on the train, and on this train, there were 3 guys that were making noise. They were treating the car like it was their party, the party environment, playing music and spitting food on the floor. And I thought, this is terrible. I'm getting out of this car. I'm going to move. And I'm just so incensed by this. Like, I can't get comfortable and I can't wait for the train to stop so I can get out of the car and get into a quieter car. But when the door opened, this little boy got on the train. And he sat down and started playing a game on his phone. Like, he didn't even notice it. Like, I'm incensed by all this chaos. And and I'm thinking to myself, well, first of all, if he's going to be on the train, I'm not going to leave him on the train. But number 2, isn't it fascinating how different our reactions were to that? Right? And it's almost like the frog that boils to death in the pot of water that heats 1 degree at a time. I mean, I feel like that's what it's like having to live in a community where there's stress all around you, that you don't even notice it, like the frog. You know this metaphor I'm talking about? If you
absolutely
a frog in a pot of boiling water, it immediately jumps out sensing the danger But if you put them in a cold pot of water and heat it 1 degree at a time, it'll boil to death.
Yeah.
That's what I think it's like for people who have to live in communities like this their whole life.
So that extreme antisocial behavior was just part of the normal ambience for this boy. So that's yeah.
I like that. Extreme antisocial behavior. That's interesting. Yeah. But it's a cultural difference. And I think that's the other thing. We have to recognize that a lot of this is about culture, and to some degree you have to respect it. But at the same time, I feel like, well, it's not okay. Like, why? It doesn't have to be this way. So, one of those questions and issues I struggle with, being in a community as a privileged person who could easily go live somewhere else, but just, I don't know. It's very interesting, very educational for me too.
I just want to clarify something here that you've said quite clearly. So you're an international doctor. You're a senior at the Centers for Disease Control. You're an epidemiologist. I assume you could earn quite a bit of cash in various parts of the world, in various parts of town, but you've voluntarily chosen to join a disadvantaged community in order that you understand the communities that you want to medically serve. I mean, does that summarize things, Lisa?
It is, and I know you think that's crazy, but the reason is because
I think it's admirable. I'm amazed. I think it's fantastic.
I know I did it because I'm a problem solver. I'm one of those people who always thinks about root causes and peeling the onion. And so I have a podcast, and I know sometimes the people I'm interviewing, they might get a little aggravated because I keep asking them why. Because, there's a theory that if you ask the question why enough, you really get to the root of the problem. And so in my work, I'm always asking the question why. And I think because of the sheer amount of money we spend. So for instance, I'm serving Medicaid populations, which is our public insurance mechanism. And that budget is over $700 billion. That's a lot of money we're spending to provide health care for poor people. But we still have terrible health outcomes. And so you can imagine me asking why, like, why is this happening? And there's tons of research looking at these problems. We're obsessed with the social determinants now, but we've known these things for decades before it had a fancy name like social determinants. There, social epidemiology research and so on. Anthropologists have been looking at these issues. The environment, your zip code determines your health outcomes. Do you have transportation to the doctor? Do you have good food options? Do you have a safe house and so on? Do you have places to walk in your neighborhood? Like, we've known these things. And so if we know these things and we also have money and we're spending it on people's healthcare, but people are still sick, I'm just sitting there, like, working at the Healthcare Financing Agency, looking at these numbers and saying, why? You're asking why. And so I thought we have to be missing something. And then on top of that, I often go to community meetings. And when you raise your hand and you say something, invariably someone in the audience who's from that community would say, well, you don't live here, so you don't understand. So I moved here, so they can't say that, first of all, because I do live here. I understand. Maybe I wasn't born and raised here, but I get it. But number two, some of the things we've talked about, I would not have known that if I had not moved to this community. I won't live here forever, but it's been an incredible education, very humbling, and just, will really make me a better doctor.
It's genuine ethnographic research, actually, for, as you say, the anthropologists would say. But, I've had a saying, for a lot of years, that healthcare should be of the people, by the people, for the people. And you have become of the people to give them the healthcare that's required. And
yeah. Well, what's interesting is, and the reason I started the podcast was because I think we make a lot of decisions for people without their input. And we don't want their voice at the table, because then we might feel obligated to do something about it if we ask them what we're supposed to do.
Yeah. Sit down, do what I tell you, and say thank you afterwards.
It's very paternalistic, absolutely.
Yeah.
I don't know if you know Richard Bomer, but he's a Harvard professor. He spends quite a bit of time in the UK. He might be there now, but we were having this conversation about how paternalistic the healthcare system is. Yes. And so I think that's worth talking about, worth putting that out there and saying, how can we be better? How can we be more respectful? How can we make healthcare more collaborative and let people know you have a say in what happens to you, whether it's, accessing your data or making a decision about, the treatments you get. Mm. But it brings me to why I'm so passionate about health literacy. Because people don't understand this, and we don't take the time to explain it to them. That you can be part of your healthcare. You can actually drive the decisions around your healthcare. But, the language of healthcare and the processes are so complex, confusing. And then the language we use to talk about it can be very off-putting and intimidating. And so, my work, I started Grapevine Health. Yep. Part of moving into the community, I started this company to make health information relatable and trustworthy, so that people could recognize, okay, I can understand this. I can do this. Like, I can understand my body, and I can speak up when I go to the doctor, and here's how. So it's been a really interesting journey. And all this.
Sorry, go on.
And this really took off during the pandemic because of all the misinformation floating around.
What methods do you use to communicate this knowledge, this information, Lisa?
Yeah, so I like to say we are a digital health company focused on improving understanding of health information through touch and tech. And the reason that touch is important, meaning you physically are in spaces with people, talking to them and listening to their concerns. And then you can digitize that if you capture it on video and then put it on the web. And then it shows people, like even in the UK, who might have a question about, well, which vaccine should I take? But they can see me on the street talking to someone, answering their question about the vaccine. And they can get the answer to their question as well. So that's what I mean by touch and tech, because tech allows you to scale your interventions, but I think we can't move to 100% digital response or a tech response. We still have to engage with people. And so that's the beauty of it. So I created something called Dr. Lisa on the Street a few years ago, and really revitalized that during the pandemic. So Dr. Lisa on the Street is just like it sounds, and people can watch videos on our YouTube channel at Grapevine Health. Yeah. And you can see me out in the community talking to people, answering their questions. And we're also building a tribe of doctors across the United States who can do the same thing in their community. So it's really exciting where we are and where we're going.
It really is. And I love that expression, a tribe of doctors.
Yeah.
A flock, a gaggle, a tribe is a great way to describe it. Yeah, and diffused across the country. People that will actually talk, come along. One of the words to me is come alongside. When someone's suffering or potentially suffering, you need to come alongside.
Yeah, walk with me. Yeah,
rather than condescend is such a critical. And this is what all healthcare providers have failed at catastrophically. The idea that I'm the big clever person, I'm going to throw a few pills down the pit and say, well, take some of those. It's yeah.
It's a good example you're raising. I think low health literacy combined with distrust really creates a perfect storm for poor health outcomes and poor engagement in healthcare. Yeah. Because, I was doing a talk at a homeless shelter in my neighborhood, and this man, I said, well, why don't people go to the doctor? And he said, well, doctors use those big words. I don't understand what they're saying. And if I don't understand you, I don't trust you. Yeah. And this is the same for us. I mean, you can tell when you don't trust someone or if they're not being genuine with you. Yeah. And so if you combine that distrust from this confusing language Why would someone want to engage in healthcare?
So it's not really a breakdown of trust. The trust was never generated in the first place.
Oh, that's right. So, and the worst time to build trust is in a global emergency.
Yeah, it needs to be there already in place, doesn't it? Yeah.
Absolutely. The public health departments, I think, and probably even around the world, ministries of health need to build relationships with community.
Yeah.
So when there is an emergency, people will trust and believe what is being communicated to them. And so we're seeing firsthand what happens when there's no trust in government or health officials. There's a real breakdown. I remember early in the pandemic in New York, somewhere in New York, they were having one of the health departments was having trouble getting people to cooperate with contact tracing.
Yeah.
So they criminalized it.
Yeah.
You can go to jail if you don't cooperate. Like that is the worst, like 180-degree, like opposite thing you should be doing, especially if you need to stop transmission of, a lethal pathogen. And so that's one of the lessons I hope we've all learned from this pandemic is that, when we're out of this crisis, health officials, leaders really need to be listening and building bridges with community, which is, again, one of the reasons I started Grapevine, so we can be a bridge between the community and health systems, because that trust has to be there. So it's almost like a trust bridge we're building. So, yeah.
The other factor, of course, is there's been some, I don't know how common it was, but it's very well publicized cases of historical abuse. I mean, I remember one study of syphilis, for example, where people weren't treated for syphilis. And the secondary and the tertiary syphilis went on, and people were just used basically as lab rats. And that's given, has that given some sort of almost institutional mistrust, some systemic mistrust, do you think?
Absolutely. And I would say as we try to roll out vaccines to communities, particularly underserved communities, for some people, that history still shapes their decisions about whether or not they get the vaccine. But what I've noticed, because a lot of our work lately in the last few months has been around just answering people's questions about the vaccine and about this pandemic. So we have Ask the Doctor sessions that we do once a week, but also when, I'm out in the community, I just answer people's questions. And I find that, the people who say, well, I don't want to be a guinea pig, because of the way, Black people are treated, I remind them that in the U.S. alone, over 100 million people have gotten the vaccine, and most of them are not Black people. So if that's your reason, because you feel like a guinea pig, like that's not a good reason to make this decision. I also talk about my own experience because I was a trial participant. I signed up to be in the Moderna trial to show people what the process was like. And this is before we even knew if the vaccines worked. And so I think answering people's questions, but it has to be a trusted, credible messenger. Really people along this vaccine acceptance continuum, I call it.
That's what I wanted to ask, actually. So basically, this is a new modality of communication, this one-to-one on the streets, in the right neighborhood, living in the right area. This is a completely new health education paradigm, really, and an impressive one. And do you get the feeling that you are communicating? Do you get the feeling you are connecting with people? Do you feel it's working?
Absolutely. Yes. And it is working. I remember one day I encountered 3 gentlemen. These are Black men who were out in the community. And I said, are you guys going to get the vaccine when it's available? Oh, no, not me. One of them said, well, I think I'm going to talk to my doctor. I might get it. But the other 2, absolutely not. And I said, well, what are your questions? And then I told them I was in the trial. And they really leaned in and wanted to know more about that. And once they told me their concerns, I answered their questions. And they were asking, well, how do I get the vaccine? And that is actually the more common response. Just last Thursday, I was doing some work at one of our public housing communities, and a lot of pushback about the vaccine. But when I asked what their concerns were, it was based on misinformation. So I think we need to find ways to get trusted messengers all across the country and even around the world where people are hesitant, to help them understand the science. But the science has to be communicated in a language people understand. Like, that's my claim to fame, that I can take this complex information and help people understand it. And that's, more healthcare providers and healthcare leaders need to do that. We need to take the time. It's a skill we have to cultivate, but it's so important because people are going to see their healthcare providers every day, and they walk out and they have no idea what the provider said. Or they're discharged from the hospital and they can't tell you what happened.
No.
So
absolutely. Absolutely.
So, and that's what drives me to make Grapevine Health successful. So I'm excited about this, as you say, new way of communication. It's not, it's just, I realize, people say you have to meet people where they are. Well, that's my definition of meeting them where they are. Like, go onto the street, listen to what they're saying. And then the beauty of it is when you have the videographer there, you can democratize this, like put it on here on YouTube and on social media and show people, okay, what other questions do you have? So I think that, there's really something here. Now, if we could just, find the right source of funding to scale this thing, I think it's going to be really successful.
Yeah, I think there's three things really. You're communicating with the individual and helping the individual at the time. You are, as you say, using electronic methods to communicate that to other individuals. But as well as that, you're demonstrating a model for other healthcare professionals to follow. So you're kind of training up the teachers. You're a teacher's teacher now, really, I think.
Well, I think it's important because in the old days, doctors used to be out in the community and going and doing house calls. And so we're seeing that now because of the pandemic. But after the pandemic is over, will we continue to see house calls and see doctors in the community? I talk about a few months ago, I talk about this story of some gentlemen I passed in the alley, and I stopped to talk to them. Because some of them didn't have on masks, and they were just, having a good old time. And one of them stopped and said, "Now, who are you? You said you're a doctor. You're not a doctor. Doctors don't just show up in the alley."
Of course not.
I had to go home and get my credentials. I even pulled up my LinkedIn page on my phone and showed them to convince them I really was a doctor. Yeah. And the reason that's so difficult for people to believe is because doctors, we're busy doing all sorts of other things. I mean, don't get me started on the administrative burden put on doctors now. But let's say we didn't have the administrative burden we have. Would we be out in the community? I'm not sure we would. So I think we need to show how important it is for us to show up, be visible, and interact with people. Yeah. And it builds trust. It really does. Now I see those guys in the alley and they wave at me.
I mean, we both laughed at that, but I think that the reason we laughed was we recognized the irony. Yeah. And it's a real indictment on all the professions that people had that attitude that there's not this sort of community engagement. It's
well, we talked about it being paternalistic, right? So
yeah.
We put doctors on pedestals here in the United States. I don't know about over there. I think it's probably less so, but it's
less than it was, but it's still
yeah.
It can be an issue.
They have you in a different class of people, even. So I remember I was riding the train one day, and I had on my exercise clothes and a baseball cap, and I saw a woman I knew, and she said, "Aren't you a doctor? What are you doing on the metro?" I said, "What do you mean?" She said, "You're a doctor. You're not supposed to be on the metro." And so it just goes to show, like, it's almost us and them. And actually, we are part of them. Yeah. And if anything, I've learned, during this pandemic that I'm more like the people I serve than I ever thought I was. So, It's all just human stuff. We're all human. We all have our issues.
Absolutely. Whatever people you work with, you soon realize that the commonalities greatly exceed the differences.
Yeah.
But one question that's come to mind in disadvantaged communities, particularly, is nutrition a problem?
Yes, absolutely. I think before the food that available in the community is nutrition literacy. So people need to understand how to choose between foods, how to read labels, how to make the best choice for themselves, even if all they have is a corner store. And we don't spend enough time talking about that. But yeah, there's a big concern about what's called food deserts. So, people like to access things that are within, a few mile radius of their house. But if you don't have, access to good, healthy food in your neighborhood, how likely are you to travel to get the food you need? But even before that, I really am insistent that we need to do a better job helping people even understand food. There's a lot of eat this, don't eat that, and this kind of diet versus that diet, and a lot of food shaming. And I think it's all very detrimental, and we need to get back to basics and just help people understand food and sort of have a harm reduction approach to food as well. So if you eat Popeyes, which is a fried chicken place that's in a lot of underserved communities, I'm not going to tell people to stop eating Popeyes all of a sudden, but I might say, can you not eat it every day? Or can you just eat it like once or twice a week? And then let's work from there. Or if you only drink Coca-Cola, can you add a glass of water, and let's build from there until you're drinking more water and less, sugary beverages. So
these food deserts, they could be really low quality food, like you've mentioned, or really high sugar, high fructose foods available.
I saw. Yeah, absolutely. Because it's, a lot of the processed foods are the foods I think that are so unhealthy for you because it has so much hidden salt and sugar. And actually, it's not even hidden. It's right there on the label. But
yeah, absolutely.
We don't give people the tools to really make those decisions.
Yeah. Did you think vitamin D deficiency is a problem, particularly in people of color in the States?
I do. And I think it generally is a problem, especially because we're spending less and less time outside in the sun. And people often think because you have dark skin, you don't need vitamin D. I'm not even sure where that came from.
Really?
Yeah.
Okay, right.
Well, there's lots of myths and sort of wives' tales.
Yeah.
In the community. So, but and this question has come up a lot during the pandemic because people are asking, well, if I get COVID-19, I'll just take vitamin D, and I have to explain. Vitamin D has been shown to affect the immune system and to, sort of help your immune system fight off infections, but that's actually before you get sick. So relying on that after I'll just get COVID-19 and I'll take vitamin D. Like, that's not the secret. The secret is to use vitamin D, regularly before you actually get sick, but afterwards, we can't rely on things like that to keep us out of the ICU or even, from dying. So,
I mean, I think especially people in even Washington, but the more northern latitudes with dark-colored skin, the amount of vitamin D you would produce is really pretty small, and and it's such an easy thing to correct as well. These are simple interventions, cheap interventions. Easy to correct. I really love this idea of health literacy. I think I'm going to want to look into that a bit more. The idea that we talk about computer literacy, words literacy, numeracy, but when you actually if you go to someone in the street and ask them the most basic thing about health, the misconceptions that are there are really quite significant sometimes. Yeah. And even for the most basic things, if you ask 9 people out of 10 to point to the liver, they won't be able to do that. The lack of basic knowledge. Sorry?
Yes, you've seen my videos. That's a true story. People don't know where their organs are or what they do. Yeah. Which is, I think it's important to help people understand so they can recognize and pinpoint health issues.
Mm-hmm. Lots of links to Lisa's videos, of course, under this. So this grapevine health, Lisa, is it? I mean, to put it quite crudely, is that your kind of day job at the moment? Is how you're making a living?
Oh yes, I resigned from my job to start a company. I started Grapevine Health because of all these challenges and issues I was seeing with the health system, health policy, and just wanting to better understand and better connect with communities. So trust is the currency we most care about. Getting people to trust us so that they will listen, understand, and then to make health decisions that affect their health in a more positive way. So yeah, it's been scary, but it's also been gratifying at the same time.
Yeah. Yeah, no, it really, it's empowerment, not aid, isn't it? You're empowering people to make their own decisions, to make their, have their own knowledge base, even if that's fairly basic. But the knowledge base that they have is accurate and not based on disinformation. So
that's right. I like to say we're in the peace of mind business, because if you think about why people avoid the healthcare system or don't want to go to the doctor or talk about their health, it's really because of what they're afraid of. Like they don't want to get bad news. I was talking to a guy on the street a couple of weeks ago who hadn't had a doctor in about 8 years. And I said, well, why don't you have a primary care doctor? And he said, well, it's sort of like going to the mechanic. I go in, for my brakes, and he'll say, but your transmission's going out. He's like, we just don't want to get the bad news. And so giving people peace of mind that this is actually something you can do. Let's help you understand it so you can take the steps to prevent your transmission from going out.
So very often in these communities there is healthcare expertise available. Not as good as we would like, I would guess, but a lot of it is attitudinal, and the access and the anxiety driven that's discouraging people from using it.
Yeah, but also we talked about how paternalistic the healthcare system is, right? We ask people to do a lot on our terms, like come here, sit there, wait for me, take this on this schedule. And we're not really trying to tailor it to people's realities or what they need or want. And it just seems like a lopsided relationship. So would you engage in a lopsided relationship?
No, indeed not. And it's not a warm welcome, is it?
Yeah. So I think there are multiple things that influence that relationship.
Lisa, thanks so much for all this time. I've taken over an hour of your remarkably precious time already. Are you planning to write this up? I mean, you are an academic, of course. Are you planning to write this up academically as well as like the propagation to this tribe of people around the United States we want to facilitate?
Yeah, I'm actually working on a book now. But what would you like to see or learn most from our experiences?
Well, I think we're at two levels here. One is that the popular communication, which I hope this is going to help, that people can see you on the streets, that people can see you interacting, that they'll see individuals are being helped, that other people will realize that help is there, and that other professionals will learn to follow your model. But governments and big funders often need evidence. They need something that amounts to evidence, because a lot of these people say, well, what is the academic evidence for this factor? And I think we have to humor these people as well, as well. So book would be good, academic evidence would be good, even if that academic evidence would probably be largely of the qualitative nature.
No, I think we have some even quantitative. We've been capturing the minds were changing, for example, by answering their questions about the vaccine. So I hear you. It's one of my frustrations, though. I am part academic, part researcher, but I'm also very much, medicine's an art and a science, and we forget about art and dismiss it as if it's not important. And I think a lot of what we're doing at Grapevine Health is art, and it feels a bit too touchy-feely for funders. But, all the things we're doing, all the academic approaches and the, quantitative and the graphs, and it's not working. So we have to find a better way if we want to reduce costs and we want to improve health outcomes and reach people, get them to engage.
Yeah.
And so that's why I've taken this very unorthodox approach. I've left my job so I can do things on my terms, and we'll see what happens. So yeah, I'm sensitive to the need to maintain that scientific credibility, because ultimately the video content we produce to educate the community is grounded in the scientific information we want people to know and use. So
yeah. Everything you're communicating is actually, as far as you can, evidence-based.
It has to be. That's where the credibility comes from, and to communicate it to the people in a way they can consume it. Because, TV doctors, people love some TV doctors, but they still speak in doctor speak. Yeah. So, I'm trying to bridge that gap, but it's hard because the academics tend to be very dismissive, and we like to put each other in buckets, right? Oh, well, you're working over here, and they don't recognize that I can actually work across these different silos. Like, that's the beauty of having all the jobs I've had in the health sector, but also being so passionate about being in community and connecting with people.
I mean, I'm not to put myself on your level at all, Lisa. I wouldn't do that. But we're both trying to communicate directly with the individuals, rather than going down through governments and various layers of hierarchy. We want to get to the business level where it's actually going to make a difference to people's lives.
Yeah, and that's the beauty of separating from formal bureaucratic agencies.
Yeah.
Because I still have the creative freedom.
Yes.
And frankly, the flexibility to say and do what I want, because I'm only worried about my own credibility and the credibility of my company. But I think as long as we're focused on the business of the people and the community, like, that's what matters. That's what's missing, and that's what matters.
Yeah. No, I think that's marvelous. And how can people help?
People can help by subscribing to our YouTube channel. We have fewer than 400 followers. I don't understand, or subscribers. So that's the first thing. Subscribe, like, hit the bell, hit the button to subscribe, so that if we get over 1,000 followers, I can actually go live with Dr. Lisa on the street from the street outside. But
listen, people, I will be mortified. I will be personally mortified if we don't get Dr. Lisa to over 1,000 subscribers. Put it on your Facebook page, put it on your whatever page it is these days, your Twitter page or your donkey page or whatever it is. Get it out there. Yeah. We need a minimum of 1,000 subscribers, and we want them quick. Please.
The subscribe button. They can also follow Dr. Lisa on the street and Grapevine Health on Instagram. But I would say the biggest need right now is a benefactor, somebody who believes in the mission and values the science behind what we're trying to do, so that we can expand the tribe of Dr. Lisas on the street across the country, and eventually maybe even around the world. Like, there's a big mission here to bring healthcare closer to people, to help people understand trusted health information from trusted messengers who are from their communities. And so this costs money to scale. And so this is not a model that fits well with venture capital funding or with nonprofit traditional mechanisms of funding. And so I'll just put it out there. We're looking for like one benefactor who believes in this and wants to help us, because then we can help millions of people.
And the other thing I'd like to say, just to everyone who's listening, this is a model I have seen working. So I've seen this with Indian healthcare workers, for example, where I can do a basic lesson, and these aren't doctors, they're not nurses. I suppose you could call them the old-fashioned idea of barefoot doctors, but they go in their own communities.
Yeah.
They say a limited amount of things. They'll use a very limited amount of treatments, but what they do use, they know is effective. And they gain they gain the trust of their communities, and this approach to healthcare, I have seen it working.
Yes, it will work. It does work.
Yeah,
and it alleviates a lot of fear and concern. That's why we're in the peace of mind business. So thank you so much for having me on today, John.
We really appreciate it, Lisa. Yeah,
amazing conversation.
And we'll talk again and make sure we've got those. If we haven't got the 1,000 subscribers by the end of the week, I'll be giving people reminders, shall we say.
All right. Well, thank you so much.
Thank you, Lisa, and it's just been fascinating, fascinating and moving at the same time, which to me is, it ticks both boxes. So really grateful, Lisa.
All right. Thank you.
Thank you.
Okay.
Thanks.
Bye-bye.
Bye.